I'm Chris Comfort. I'm currently the Chief Operating Officer here at Calvary Hospital in the Bronx. We're a 225-bed hospital, a special hospital, because the work we do really is with patients who have extreme care needs at late in their illness or even at end of life. I've been with the organization now about 20 years. I spent the first 18 of those years as the medical officer here.
Has that been a big increase in stress for you?
Not really. I think I had the fortune or the misfortune of doing all of that over COVID, the real stress that everyone has felt in the medical community.
Well, we're going to get to COVID, of course, but we're talking about palliative care first. November is National Hospice and Palliative Care Month. Let's start, though, with palliative care.
It is National Palliative Care and Hospice Month, and you notice that we squished both words together, but I'm not sure people really understand clearly the differences behind it, and honestly, I'm not sure I do, having done it for 20, 25 years. Palliative care is an idea of thinking about the way that you take care of people. One is it concentrates on the idea of understanding the illness of the patient, and the idea is for caring for patients during that time. Although the idea of improving survival or the idea of curing can be part of the care that's delivered, this is a concentration on making sure that addressing how somebody feels during the period of time of intensive treatment or even non-intensive treatment is addressed. We concentrate as specialists in making sure that pain's controlled and also the management of symptoms that are fairly predictable in particular disease processes such as nausea and vomiting, confusion. The history of this really is that it comes out of the oncology world. Second part of it is the idea of who we're taking care of. Although we recognize that the patient, the one with the illness, is the one who is suffering and the one who needs to be cared for, I think our experience, especially with patients who have chronic illnesses or in later stages of their illness, these diseases seem to metastasize to the family as well. And families, especially if they're involved with the loved one, really suffer along with the patient. And there really is a need to be caring for the family as well. So we say that the patient no longer is the unit of care, that the family and the patient become the unit of care, that group that gets cared for. And gone are the days of the grand and glorious physician deciding what is best for the individual. This is shared decision making. What are the options? And a discussion of those so that the direction of care can clearly be aligned to where the patient sees themselves going.
I will always get a pang in my heart when I hear the word palliative, because the first time I really heard it and dealt with it was when my late husband, was doing poorly with cancer. And I suppose I was just so focused on his care, getting him to radiation, that I asked a question, and the person in charge of radiation, not at Calvary, I might add, but somewhere else, but told me, oh, well, this is palliative care. This is palliative care, Pat, and dismissed me. And that was the first time I thought, wow, he might not make it.
And it's interesting that it has become a buzzword.
Yes.
In other words, it's become a way of communicating by the general medical community to gently let individuals know, whether it be patients or families, that in fact the disease may have taken a different trajectory.
Yes.
And I think that one of the approaches that we've taken for a long time here, and I think works quite well, is instead of telling, asking. It's fascinating that families and patients, as they go through these difficult times, have an innate and instinctual understanding of what's going on. They may not be able to articulate the diagnosis, but they have an instinctual understanding of how things are going. And the idea of asking or validating those kinds of feelings is so important in bringing a patient or a family along with that understanding.
It really is.
It doesn't change anything,
no,
because what will be, but it actively involves and gives power back to patients and families so that they don't feel so out of control and powerless.
Yeah, that was 20 years ago that I went through it, and it's still, I can get a pang and remember exactly how I felt at that moment.
Well, when you think of the long list of memories that you could have, And the fact that that one rings true and in the distant past still has such significance really tells us how important these conversations are. For us, especially taking care of patients who are in some of the later stages of their life, you get one chance. You've got one chance to get it right. You've got one chance to say the words that need to be said. You've got one chance to understand and participate in an event that is as blessed as birth, and understand that that memory will go on with the family for years and years and years. There's an expertise to it. There's an art to it. And I think palliative care describes those physicians that try to make those kinds of discussions appropriate to lead to better memories as we all look back on those difficult times we go through in our life.
And I think Calvary Hospital really gets it right. Does palliative care extend life or the quality of life?
I think it's interesting that 20 years ago, you heard palliative and it meant that your loved one was doing poorly and there may not be anything more to offer. That concept has matured. There was a fascinating study that came out of Harvard, 10 years old, took lung cancer patients and at the onset of their treatment, provided them with palliative care. Specialists came in to talk to them, and similar group had just state-of-the-art treatment for lung cancer that had spread and was stage 4. I think the authors of the study thought that they would do better in terms of feel less depressed. They would feel more connected. They would feel like their goals were respected by the care team because they had an advocate in palliative care. But to everybody's surprise, when they looked at the results of the study, the group that got regular treatment plus palliative care actually lived 3 months longer than the group that got treatment. I, to this day, don't know what it is about someone intervening and using the techniques of the work that I do every day would extend survival by 3 months. So the movement now is to move palliative care out of the realm of a specialist that typically has been a hospital-based specialty into the community and provide that skill set for all doctors. The movement has even been justified in the approach New York State has taken in terms of its legislative activity, where they have mandated education in palliative care for all physicians.
I'm sure it's partly the answer to my next question. What can we do better so that people are much more prepared for end of life?
I think discussions and a realistic approach to caregiving, the work that Pat Bombach has done. She's running the project really for the MOLST here in New York. The MOLST is the Medical Orders for Life-Sustaining Treatment. That we start early with the fact that this may be an illness that the patient has that really does affect longevity, does affect the quality of life as they move forward, and have those difficult, sometimes, discussions. I mean, I can't imagine that someone who has a significant illness with chronic lung disease, the patient with congestive heart failure, who now, instead of walking unlimited and no shortness of breath, finds themselves stopping at the top of the stairs and huffing and puffing, having to wait. They know and they understand in their own way.
Do you find a lot of people who are seriously ill, do most of them accept it, or are there a great number who seem to pretend it's not there?
Patients are amazing. We adjust to disability. We adjust to reductions in functions in amazing ways, where significant reduction in function is surprisingly tolerated by individuals in terms of their mindset. They adapt to it. Most remain very optimistic about what the course of illness will be. The best predictor, I think, for them is their honest interpretation of how they feel. And that means that as they get sicker, they intuit that things have changed. Families, on the other hand, don't have the opportunity to experience that. They don't have the illness. They don't have the shortness of breath. They don't have the pain at night. They don't have the limitations that the person who's ill has. And they have a harder time being realistic about it. And they have another difficulty because what they're trying to do is they're trying to protect the loved one. And so a discussion or an admission of the illness is difficult for them because they are in a position where they don't want to make things worse. Some of that is cultural, but I think in general is not an uncommon phenomenon patients who may stay very positive and be very aggressive about the treatment that they want. That is often based on, how they perceive themselves and how they feel.
Yeah.
Families, on the other hand, I think, are a little bit in the dark because they don't have that same experience of the illness, and they're very protective mechanisms that loved ones go through, that we try to protect each other from difficult times.
That makes a lot of sense. Well, segueing to the Medicare hospice benefit, how can people activate that?
The hospice movement, probably beginning in the 50s, grew out of the nursing profession, not a doctor thing. It was addressing a poor dealing with end-of-life care of patients. It was a philosophy of care. It was philosophy that says, care if you can't cure. Make people extremely comfortable. Make it a personal touch. Physical presence is important. Hand-holding, even into the last days, was essential. Adequate pain control was essential. That grew into a movement that in the 80s was recognized by Medicare as a very legitimate type of care. The election of that benefit is really no different than it was in 1982. The physician caring for the patient attests to his prediction that survival is less than 6 months with the illness that the patient has. The patient then is able to decide that they would like to be cared for in that hospice. And the hospice steps in with very particular services. Very experienced nurses come into the home to begin the process of management of pain and other symptoms. There is a strong support system that is built for social services and social work, both for the needs of the patient, but addresses the needs of families. Custodial care or day-to-day care of the patient becomes very important because as these individuals become weaker and weaker, their care needs at home increase. And so there is provision of home services by the hospice, as is allowed by Medicare. Medications are included in the care so that there is no additional cost to the individual, to the patient, or the family for the medications that are given during hospice. Those medications are customarily delivered to the home rather than the patient or the family having to scurry out to the pharmacy. And then one of the novel concepts of hospice, which was, I think, revolutionary in 1982, was the idea that to be eligible to provide hospice services, the hospice had to have bereavement services. Services for the family after the patient dies that need to be delivered for a 13-month period of time after the death of the patient, which addresses the needs of families over that year after death, checking in with them, making sure that there are not individuals within the family who are at very high risk of difficult or painful grief. So the election process, I think, is a discussion related to, first, the goals of care, where they see the illness going, and then what the goals of that care are. These days, still, most hospice beneficiaries are electing the hospice benefit with a very short time between election of the benefit and death. The average length of stay in hospice generally here in the United States has climbed, but it's still sitting at about 40 days. This is not that long. If you look at some diagnoses like oncologic diagnoses, that average is sitting somewhere around 20 days.
Moving on to COVID, describe, if you would, how the pandemic has affected Calvary.
So this was a unique experience for us. The pandemic hit, and we were given a reprieve of about a week and a half because we customarily are taking care of patients after discharge from the acute care system. There were a number of factors that led to patients coming here. One was that, as you know, we pretty much closed the nursing home system down to COVID-positive patients. So when you think of the usual course of patients in hospitals who are really, really sick and maybe too sick to immediately go home, we customarily would have had those patients in skilled nursing facilities. I will tell you, I was shocked at the length of time for patients who had respiratory compromise. Those respiratory symptoms in some of that population lasted for weeks. That means that that kind of a patient was really a very high-risk patient to be cared for in other than a hospital setting. And coupled with the fact that it was not possible to discharge patients to skilled facilities, we had a significant number of patients who came here to Calvary from all over New York City. This was an event that was like no other because of the sheer volume of patients who went into the acute care system. I can tell you we worked tirelessly night and day, including weekends, on the phone with discharge resources from all the facilities here in New York to move patients through the system as quickly as they could be moved, because any gum up in that system meant that it was impossible for the acute care hospitals to provide the very high level and quality Herculean care that they were providing to the desperately ill who came into the emergency room in droves. The hospice was, for the first 2 weeks of the pandemic, I think, was the only hospice here in New York City that was accepting COVID patients. So they had a huge number of patients who were discharged to home, and we became responsible for really taking care of a extremely high risk and very, very ill population who were able to be discharged to home. I was really moved by the work that the hospice did because, as you know, you saw demonstrations of frustration by medical workers, all acute care hospitals, because of the risk of being exposed to COVID, the PPE difficulties. Well, this was a group, this hospice providers was a group that went into the home, went into harm's way without the ICU, without the structure of controlled medical wards and PPE, and had to develop protocols for protection of themselves. Well, boy, it's a lot different trying to provide that care in the home setting than it is in the hospital setting. So these are people who really went into harm's way in a way that I don't think many of us really appreciate, and was really spectacular, heroic in my view.
It's amazing. And now, are we in the second wave, would you say? Is Calvary dealing with the second wave? Or are we well into it, or is it starting, or what do you see?
Well, I can tell you, I don't think New York's gotten to the second wave. I mean, the first wave was very distinct. The volumes in the hospitals were amazing. The stays in the ICU and the occupancy of the ICUs were astounding. The governor called out for all institutions to double their capacity, which all of us did. But I think at this point, New York City has not seen that uptick in terms of extraordinary hospital stays that, let's say, the Midwest has seen at this point. Some of that is because of really the fine work that's been done related to a very, very measured and organized response of the state. Some of that is due to testing and the idea of quarantine for individuals here in New York. We have done very well. I don't see the wave yet. It's not to say that we won't, but I certainly don't see the wave yet.
Do you see, or do you feel that there will be an uptick as we get into the winter?
Yeah, I think the winter's a difficult time for us. There's been a bit of an uptick locally, as you know, from clusters here, even in New York City. We follow fairly carefully from other facilities what their ICU census is and whether they see upticks or not. One of the benefits, I hate to say it, but one of the benefits of this pandemic is that communication between institutions now has become commonplace. We've now become a connected community because it's very important to know what's happening not only in the center of things for us here in the Bronx, but important since our referrals come from all over, for us to understand what the experience of healthcare providers in the tri-state area is, because it gives us an idea of what's coming our way. The winter is a difficult time, and I think, just a plug here, we've been very strong with our staff to indicate that the flu vaccine is essential. And this year it's different. The flu vaccine is always essential. So we tell our staff, get vaccinated, get vaccinated. You're protecting the people you're taking care of. On the other hand, this year, it is get vaccinated, get vaccinated. It is the most confusing thing in the world to have an ER full of people where you don't know whether it's influenza or COVID. So it's a big deal for a different reason this year, and it facilitates being able to differentiate between influenza and COVID. Wintertime's a time when everybody's indoors, closed spaces accelerate the transmission of the virus. So we're watching fairly carefully here, encouraged by information related to a vaccine. I think that since that will be prioritized, I think probably to healthcare workers first, because of the need for essential workers to be able to be available for work. But that's encouraging because it means we're getting close to where we can address the issue of cure of this or prevention. And hopefully we're on the cusp of that right now.
Well, Dr. Comfort, you have been fantastic. Anything else you want to throw in at the end of our interview here?
No, I think I want to thank you, Pat, because, there's not a lot of opportunity for a fairly detailed discussion of all of this. reports in the press, they tend to be a little bit obtuse. Even the information that's given out often isn't frontline information. I certainly think we probably are at a point now where voices from the front related to COVID, with a real description of personal stories related to it, as well as an overarching view of where we are from frontline medical personnel, probably is extremely helpful for the general population, because it gives them, I think, information that is concise, real time, and also based on personal experience that may be very peculiar to geographic areas like New York. I think a discussion of the fact that COVID was an illness that had a reasonably high mortality here in New York City, it does help to understand the nature of the disease. I'm fascinated by post-COVID complications. We're finding that the complications of having the illness, especially in terms of chronic fatigue, more importantly, some neurologic syndromes, we have a very poor understanding of. And I'm not sure we really even know the natural history of them. So there's lots to be learned. And I think by keeping our minds open, we'll be well on our way to doing some good work in being able to address the issue of complications.
Dr. Comfort, thank you for allowing me to monopolize so much of your time today, but it was really worth it. And I hope you'll allow me to call you back at another date down the road a few months to see how we're all doing.
Oh, please do. We'd love to chat.
All right, okay. Doctor, have a great day.
Thank you.
All right, bye-bye.
Bye-bye.